Good afternoon, professor and classmate. The subject I am going to talk about cardiac metastasis in melanoma. Definition: cardiac metastatic invasion to the malignant melanoma is frequent, but the clinical repercussion is scary and usually occurs in a silent manner.
So I'm Tim Shirey, and when I was 47 years old, I was diagnosed with stage 4 metastatic melanoma. My symptoms were a black, purple, ugly nodule growing on the back of my neck. And I was aware it was there, but I covered it up with a Band-Aid and tried to put some stuff on it, and actually just didn't want to accept I didn't know what it was, but I knew it wasn't normal. I went to my family doctor, and he took one look at it, and he said some words, and I knew it wasn't good. And I was at work 7 to 10 days later, and my mom had told me that you got melanoma cancer. I remember my first visit vividly. It was on the 9th floor. It's no longer being used for what it was then. The room was full. I was with my 2 brothers and my nephew, and I was very nervous. We got the paperwork done, and a lot of paper. Probably spent 3 or 4 hours there, and I was officially registered at MD Anderson. I went straight to the oncologist, Dr. Who, and I had surgery on that spot that the doctor cut off. 2.5, 3 hour surgery. And the prognosis was very good. It was not in my lymph nodes, and everything was good. Dr. Who put me on a type of chemo called interferon. The interferon, I continued 4 months at home giving myself a shot 2 days a week. I went 4 months, and then I'll never forget it. It was a Saturday morning. I was on my way to work, and I had my jacket in the back, and I put the jacket, I knew what was coming, I put the jacket on my lap, and as I'm going down the freeway, I started throwing up. And I had tears. I was very upset emotionally as well as sick. And I called my mom, and I said, Mom, I can't do it no more. I can't do it, no more interferon, we're done with it. Dr. Who was all for it. He knew I gave it my best shot. Dr. Who was very personable, very knowledgeable. And every time I visited him, we talked about bowling, football. He always has analogies of what I was going through to like a football game. I remember one time he said, Tim, we're throwing a Hail Mary, and stuff like that. So I could relate to it, and we always hit it off. And he's one of my best friends.
Application y the nursing. Care of the cancer patient is different styles and the processes. Performing support therapies in addition to improve healthy lifestyle. Also treat symptoms, including other physical problems caused by cancer or its treatment.
You've just been diagnosed with melanoma. Naturally, you have concerns and many questions. What are the latest new treatments? What is the right treatment for me? Are there clinical trials available? We've got answers to those questions and many more right here. Over the past few years, there has been remarkable progress in treating melanoma. In advanced stages, the melanoma has spread from where it first started and traveled throughout the body. Stopping its growth is critical, and there are now 2 breakthrough therapies to do so. One is called immunotherapy, which supercharges your immune system so it can identify and destroy the melanoma. Another cutting-edge treatment is targeted therapy, where we learn which genes in your cancer are broken and then target powerful medicine directly to the damaged genes. First, let's take a closer look at how immunotherapy works. Immunotherapy revs up a patient's immune system, specifically the body's T cells, the powerful police force in the body that fights infection and disease. Normally, your immune system automatically detects and destroys anything it finds that can harm your body, while leaving healthy cells alone. But melanoma cells disguise themselves as healthy ones, tricking your immune system into ignoring them. The medicine used in immunotherapy supercharges your T cells so they can see through the disguise of the cancer cells. Your immune system can then do what it does best: destroy what's harming your body and get you healthy again. Immunotherapy is normally given by an IV drip in an outpatient clinic. It can take longer to work than targeted therapy, but may work much longer and is effective against more types of cancer. But what if immunotherapy isn't right for you? There's another promising treatment called targeted therapy, and here's how it works. Your body is made up of trillions of cells, and when you're healthy, all of those cells grow at a steady, regulated rate. But in melanoma, the cancer cells don't work properly. Normal genes like BRAF and a few others are broken or mutated, and these genetic mutations cause the cells to rapidly grow out of control. This is how melanoma can spread to other parts of the body. Targeted therapies are designed to stop those out-of-control cells from growing. First, doctors perform genetic testing to learn precisely which genes are broken in your melanoma cells. If we find that the BRAF or other recognized genes are broken, then we can tailor a personalized therapy that targets your specific cancer cells. The medicine works to shut down the broken gene pathways, helping shrink the cancer and stop its growth. For most patients, targeted therapy works very quickly and effectively throughout the body. Targeted therapies come in pill form and are taken at home while you go about your daily life. So how do you know which treatment is best for you? That depends on your unique genetic profile, symptoms, and medical history. You and your doctor will work together to determine the specific therapy or combination of therapies that will be most effective for you. Here at Penn, cancer research is evolving every day, and for some patients with advanced melanoma, a clinical trial may be another alternative to consider. Whether you're considering targeted therapy, immunotherapy, or any other form of cancer treatment, Penn's Abramson Cancer Center offers the most cutting-edge therapies, research, and clinical care in the country. At Penn, we focus on the whole patient, bringing together doctors, nurses, nutritionists, social workers, and physical therapists to treat your physical and emotional needs. We know that a melanoma diagnosis can be difficult. By arming yourself with knowledge and asking the right questions, you're taking critical first steps toward a cancer-free life. For more information on Penn's breakthrough therapies for advanced melanoma and other forms of cancer,
Pros and cons.
My name is Rich Joseph. I'm a medical oncologist at Mayo Clinic in Jacksonville, Florida. My clinical expertise is in cutaneous malignancies, including melanoma and other skin cancers. And I also treat genitourinary malignancies as well. So melanoma is distinct from other skin cancers in that it is usually a proliferation of pigmented cells, although not always. Melanoma can also originate in different parts of the mucosal tract, including the head and neck, as well as the GI tract, as well as on the bottoms of the palms and the soles, which usually doesn't occur in other types of skin cancers. Melanoma is the most deadly form of skin cancer because it is the cancer that is most likely to spread to other organs. Other types of skin cancers rarely spread from outside of the surface of the skin, and the ability of the melanoma to metastasize makes it the most deadly. Stage 1 melanoma has a cure rate of about 95%. So if you catch it early, that's great. A thicker melanoma is something that is still in the skin but has not spread to the lymph nodes or the rest of the body, still has a pretty high chance of cure of catching it early, somewhere in the range of 70 to 80% chance of cure. Stage 3 melanoma is when the melanoma has escaped from the skin and gone to the lymph nodes. And we divide stage 3 into stage 3A, B, and C, depending on how many lymph nodes are involved. And the cure rate there drops all the way down as low as 20% if many lymph nodes are involved, and as high as 60-70% if only one lymph node is involved. A stage 4 melanoma is a melanoma that has left the lymph nodes and gone to distant parts of the body. And there, the survival is much less. The overall average median survival is, we're talking in the order of months to maybe a year or so. However, those numbers are getting better with our newer therapies. I see melanoma patients usually at 2 phases. The first phase is if they are diagnosed and then they have a lymph node that is positive. Traditionally, the lymph node is removed by the surgeon, and then they come to see me to help them prevent the melanoma from recurring in the rest of their body. And at Mayo Clinic, we have several clinical studies that are geared towards preventing melanoma from spreading to the rest of the body, which we call stage 4 melanoma rather than stage 3. Melanoma does predominantly exist in an older population. However, the amount of numbers in the younger population is much higher than other types of.
Pros. Target therapies improve treatment options for melanoma, bringing new hope for patients with events and metastases. Currently, drugs use some of the approved by the United States Food and Drug Administration, FDA. And cons. Generally, the cardiac condition is silent and the pre-mortem diagnosis is rare. Other times, the patients suffer from non-specific symptoms such as asthenia or intolerance to exertion, which are attributed to other causes. Issue apply in Ecuador. The WHO warns the global insight of the disease doesn't stop growing. According to that of Solca, malignant melanoma is cited as a spike if the 14. There are around 250 new cases each year, being real by quite a little. It is especially a problem here as we're closer to the sun and there are more exposed UV rays.
Je suis biologiste, je travaille dans le domaine du cancer et notre équipe s'intéresse aux protéines qui sont impliquées dans le cancer et notamment une famille de protéines qu'on appelle les protéines RAF. Il y a une dizaine d'années, l'une de ces protéines, la protéine BRAF, a été montrée comme étant mutée dans le mélanome, qui est un cancer de la peau. En fait, la mutation BRAF induit une prolifération anarchique des cellules pigmentaires qui va aboutir en fait à la cancérisation de ces cellules. Et ces cellules pigmentaires sont celles qui sont responsables de la pigmentation de la peau, des poils et des cheveux. En fait, la protéine BRAF, on la connaît bien puisqu'elle a été clonée, son gène a été cloné dans notre laboratoire. Et on se doute depuis longtemps qu'en fait, elle n'agit pas toute seule. Et donc concrètement, ce qu'on a fait, c'est qu'on a supprimé l'expression de la protéine BRAF et d'un autre membre de cette famille, la protéine CRAF, dans les cellules pigmentées chez la souris.
And in conclusion, metastatic cardiac tumors are extremely rare. New diagnostic technology and improved survival of oncological patients might increase the insight of metastatic cardiac tumor in the future.
In this video, we're going to look at melanoma. This is an overview of melanoma, an introduction. Melanoma is cancer of the skin. Melanoma has the highest mortality rate of all dermatological cancers. Melanoma is also one of the most common cancers in young adults. So what are some risk factors for developing melanoma? Well, some common risk factors include having a family history of melanoma, having a personal history, having light hair color, light eye color, having a high freckle density, being immunosuppressed either because of the use of drugs or having a particular disease, and having multiple melanocytic nevi, essentially multiple moles. So how does melanoma look like? Well, melanoma looks different in each individual. So let's zoom into this person's face. And here's a cross-section of a skin with melanoma. Let us compare this to a normal skin cross-section. The top layer of our skin is known as the epidermis. Below the epidermis is the layer called the dermis. Below the dermis is another layer known as the hypodermis, which contains subcutaneous fat, which is important for thermoregulation. As I mentioned, melanoma is different in each individual. However, melanoma is usually always pigmented. It's a pigmented lesion, it's often asymmetric, it has ill-defined borders, and melanoma often bleeds and or ulcerates. So how does melanoma develop? Well, let us zoom into the epidermal layer of the normal skin and compare it to the epidermal layer of a skin with melanoma. We are now looking at the pathology of melanoma. So here are some cells that make up the epidermis. Here again is our epidermal layer, and below the epidermis is our dermis. In between the epidermis and the dermis is our basement membrane. Essentially, this is what separates the epidermis to the dermis. Just above the basement membrane, we have a special cell of the skin known as melanocyte. Melanocytes are important for us because they help protect us from UV radiation, and they help in our skin pigmentation. In melanoma, what happens is we have proliferating melanocytes. So these melanocytes that are normally harmless become mutated, and they grow and divide rapidly, resulting in melanoma. These risk factors can lead to these proliferating melanocytes. When going to a doctor and if suspected of having melanoma, it is important to examine the skin lesion. A good way to examine the skin lesion is to follow the ABCDE rule. So in A, we look for asymmetry. In B, we look for ill-defined borders. In C, we look for any color changes or even bleeding. In D, we check for the diameter and possibly the depth. And E, possibly the most important, is we look at elevation and in particular evolution. So if the skin lesion changes quickly or rapidly in a short duration, melanoma is suspected. There are ways to prevent melanoma. These include wearing a hat, using sunscreen, wearing long-sleeved shirts, protective clothing, especially if you work outside a lot, wearing sunglasses, and also, if you have a family or personal history of melanoma, having regular doctor skin checks or even self-skin checks. So that was an overview of melanoma. Thank you for watching.
Thank you very much for your attention.